Good evening and a very warm welcome to the Heart Health panel discussion. We were just talking a few minutes ago about how excited we are for this evening's discussion. My name is Melissa Weaver. I am the Member Services Manager at Here for the Girls, and I would like to provide a very special thank you to VCU Massey Cancer Center for making today's event possible. So we are joined by three extremely talented colleagues, and I wanted to just give a brief description for each one of them before we get started. So Arnethea Sutton, PhD, is a postdoctoral fellow, Department of Health, Behavior, and Policy at VCU Massey Cancer Center. Her expertise focused on identifying causes of racial disparities in survivorship, with a particular focus on treatment-related cardiovascular toxicities. So Arnethea, we are so grateful and excited to have you here with us. Alex Lucas, PhD. Alex is the Division of Cardiology, VCU Pauley Heart Health Center and Department of Health, Behavior, and Policy. The expertise focus on the design and delivery of behavioral lifestyle programs, physical activity, sedentary behavior, nutrition, and stress management to manage long-term health and quality of life among populations with chronic disease. And we also have Samantha Haswell with us this evening. We're so excited, MSRD. Samantha is a clinical dietitian at Massey Cancer Center. Samantha assists patients with all types of cancer in managing their symptoms during cancer treatment, preventing malnutrition, and maintaining a healthy diet following cancer treatment and into survivorship. Again, a very warm welcome to our speakers this evening. We are so grateful to have you. And I think that Arnethea is going to start us off this evening. Thank you so much, Arnethea.
Thank you so much for having us, Melissa. We're all happy to be here. Like she said, my name is Arnethea Sutton, and I am a postdoc fellow in the Department of Health, Behavior, and Policy. And my work does focus on trying to understand racial disparities in cardiovascular disease after treatment. So I'm going to share a little bit with you all today. Some of the work that I've been doing, it's good that I'm going first because I'm going to kind of lay the foundation about what we know with regard to cardiovascular disease after breast cancer and treatment and what we're trying to do about it. And then my colleagues after me, it's like a perfect placement because they'll be able to talk about some ways that we can maybe mitigate some of these issues. So I wanted to start overall, like just talking about heart disease in general. So heart disease amongst women in the United States. There are approximately 47.8 million women in the United States that have some type of cardiovascular disease. And the numbers show that about 1 in 16 women over the age of 20 have coronary heart disease, which is the most prevalent type of cardiovascular disease. But unbeknownst to many, heart disease is actually the #1 cause of death for women in the United States. And studies show that about 56% of women are aware of this fact. So most are aware, but there's still a large percentage of women who are unaware of the fact that this is the #1 cause of death. The numbers are a little bit mixed. So I've seen about 1 in 5 female deaths are attributed to heart disease. I've also seen about 1 in 3. So we're somewhere between those two numbers. But still, we see that, this is clearly a huge burden for women in the United States. So what about breast cancer survivors and what do we know and what's happening? So I have a picture here of this really amazing paper that came out that looked at this intersection between cardiovascular disease and breast cancer. And what it did was it talked not only about the incidence of breast cancer in the United States and cardiovascular disease, but how the two meet and how they merge. And I know that Samantha is going to talk a little bit about that as well. I highlighted this paper as well because I know everyone does not have access to really good reading that we may have in academia. So if this looks like something you may be interested in, I'm sure through Melissa and others at Here for the Girls, you can contact me and we can get you access to this paper, but just a great paper. So this is what we know. So studies are showing that amongst older breast cancer survivors, and typically when we say older, they're talking about women who are at least 60 years of age or older. So we're looking at the development of cardiovascular disease risk factors. So those are things such as hypertension, diabetes, obesity, development of cardiovascular disease in and of itself, and mortality as a result of cardiovascular disease. So any of the cardiovascular disease risk factors or death because of cardiovascular disease, the risk is actually higher than a risk of a breast cancer recurrence. And studies are showing that even amongst older women with breast cancer, they're more likely to succumb to cardiovascular disease than they are to breast cancer. So this just lets you know, this lays a foundation for why it's very important for us to start to look at the heart health of women as they're going through treatment and post-treatment, because we see that later on in life, this can potentially become a huge issue. So where does it come from? You know, these here are, I've highlighted some of the therapies that we typically study with regard to cardiovascular disease. Your anthracycline-based chemotherapies, and most women are familiar with doxorubicin, as that's typically one of the anthracyclines that are used. Trastuzumab, which is the generic name for what we hear as Herceptin, or the drug that's prescribed to women that have HER2-positive breast cancer. Even left-sided radiation, so women that have breast cancer within the left side of their breast, they receive radiation on that side, and we know that the heart is also on that side. And while providers do everything they can to try to protect your heart during that treatment, there are potential risks of heart disease. The last I have here is endocrine therapy, and I have a question mark there because this is one that people are trying to understand and explore. There definitely are some mixed findings there. So what we've seen in some studies is that there were concerns about aromatase inhibitors causing cardiovascular disease. Now you're starting to see studies that say it might not be aromatase inhibitors that are causing it when comparing it to tamoxifen. It might be tamoxifen that's actually more cardioprotective. And that's why you see less women who are on that actually have cardiovascular disease. Like I said, these studies, you know, we have these mixed findings, and there are lots of scientists who are trying to disentangle this and understand this, but we definitely are looking at endocrine therapy. But definitely the top three are the ones that you see typically when we're talking about the implications for cardiovascular disease. So different types of cardiovascular dysfunction that, you know, we study and that we're looking at. And this right here was a nice graphic that I pulled from a consensus statement that recently came out that just kind of discussed the different types of cardiovascular disease. So you see cardiac dysfunction and heart failure, myocarditis, arrhythmias, and there are tons of arrhythmias, including atrial fibrillation that most people are familiar with that fall in that. Vascular toxicity, so we're talking here like your strokes, you can talk heart attack or ischemic events. And then I like to highlight the last one because hypertension. So typically people think of hypertension as a risk factor for cardiovascular disease, but this consensus statement now is looking at it as actually a cardiovascular dysfunction as a result of treatment. So how is cardiovascular dysfunction diagnosed? You know, the NCCN, they are like one of the bodies that create guidelines for care for cancer. Around 2014 or 15, they stated that echocardiography was the standard by which individuals should be assessed for cardiac dysfunction after their diagnosis. But we also know that individuals can be assessed through MRI or MUGA scans. You can see here through this graphic, depending on the type of treatment you have, there are different times which you may be assessed. So baseline, so before you start your treatment, absolutely. So if you're an anthracycline therapy or you receive trastuzumab or a combination of both, then they will assess you at baseline. If you receive trastuzumab, then you're going to be assessed, or you should be assessed every 3 months throughout your treatment. Anthracycline, it actually depends on the type of dose, the amount of dosage you receive of it, whether or not you're assessed through treatment. But after treatment, according to the NCCN, women should receive an echo within 12 months of their treatment. So that's important to remember. I have here circled this no routine testing of asymptomatic. And I'm going to bring that up because I've had some dialogue with some women who were going through treatment and completed treatment about this idea of like symptoms of cardiovascular dysfunction or symptoms of heart failure. And, you know, I believe that there's a lack of knowledge amongst all of us of what that even looks like. So if you take a look at this slide here, you'll see a host of different symptoms. And these symptoms are typically attributed to heart failure. They definitely can be attributed to other chronic diseases and other things, but I want you to just familiarize yourself with some of these things here. And I will note at the bottom, SOB on this slide is shortness of breath. So we have here extremity edema, or you have like swelling, shortness of breath, as you can see, while you're lying down, while you're active, if you're at rest, if you're waking up at night and you have shortness of breath, fatigue and lack of energy. I know one time I was talking to a woman about this, and she stated that, I walk my kids to the bus stop and I get very tired sometimes at the stop, but I know that's just because of my breast cancer diagnosis. And, that lets me know that we have a lot of work to do, because while that may be true, it may also be because there's something going on with your heart that needs to be communicated with your provider. So as far as the treatments are concerned, I decided to give you some numbers so you can see what we've seen. So these numbers here are from a large study of over like 13,000 women with breast cancer, and they receive these different treatment modalities. Within the first year of treatment, you can see on the top, the different percentages of women who had a kind of cardiovascular dysfunction, anywhere between 1.2% for women just on anthracyclines to up to 6.2% for women who had a combination of both. But the numbers underneath show where the numbers were within 5 years. So 5 years after treatment, as you can see, the percentages go up as high as 20.1% for women who have both anthracyclines and trastuzumab. And because I am a disparities and equity researcher, I thought it was important to bring this notion up. And so we're concerned about cardiovascular dysfunction overall, but we also know that Black women have higher rates of CVD dysfunction when compared to white women. And so in one study that looked at women with HER2 positive breast cancer and declined ejection fraction, they found that within the first year, 24% of the women, of Black women, suffer from declined ejection fraction, and only 7% of white women. And so we definitely have to understand cardiovascular dysfunction as a whole and understand why we see these racial disparities. So we always talk about the problem, but what are we doing about it? And so here at VCU, we're very fortunate to have the VCU Pauley Heart Center and Massey Cancer Center both working on this problem. And over the past couple of years, two disciplines kind of come together. So you have the cardiologists and the oncologists have now come together for this field that's called cardio-oncology. And I'm happy to say within cardio-oncology is not one of those fields that's just like, oh, a new buzzword or a new name. With this field have come a wealth of expertise, like you will see on this panel, that are coming together to help solve this problem. And with this new field also comes more money. And so now we have funding agencies who are interested in understanding why we see issues with the heart throughout survivorship. And so they're funding more work to be done in this area. And so briefly before I end, I just wanted to talk to you a bit about some of the work. There are others here at the institution who are doing work within this space, but this is also some of the work that I'm doing. And so I was fortunate enough to be funded by the National Cancer Institute to do some work to understand why we see racial disparities and cardiotoxicity. And so what I've done so far, I've done interviews with Black and white women, and they've all been diagnosed with breast cancer. They all received either anthracycline-based chemotherapies or trastuzumab, and they were no more than 2 years out from completing treatment because I wanted them to be able to recall. So they were talking to me about their experiences going through treatment, their experiencing having echoes and getting their heart assessed, what type of dialogue they had with their providers or nurses about their treatment, et cetera. And so here are some of the quotes that we found. So one woman talked about, did your physician talk to you about your heart or about the side effects of your heart? She said, if she mentioned it, maybe I just didn't understand her. While another woman said, Herceptin in particular could impact the ejection fraction. So that shows you like the differences of what women remember, maybe what was shared with them. And then we also have, how much would women want to know about their treatment side effects while they're going through treatment? And one woman said, I'm just trying to stay alive right now. Everything else is just peripheral. While the other woman said, I would have appreciated repetitive reminders. And so this just lets you know how women have different needs and preferences and values with regard to the type of care they receive, the type of communication they have. And so this type of information will help us when we're trying to determine what type of interventions and what kind of communication we need to have to make sure all women know what is to come. And right now, we're doing an analysis of hospital data. And so this data, I have over 850 women. And so in this group, 40% of them have experienced some type of cardiovascular dysfunction, either during treatment or after. You can see here the high numbers of the risk factors that I discussed. So like over 73% have overweight or obesity, 78% receive trastuzumab. I'll point you to the square where you see 13.8% had hypertension, 7.3% had diabetes, and the numbers in parentheses are actually amongst the women that had hypertension, 71.8% of them were Black women. And amongst the women that had diabetes, that was 69.4%. So this also highlights the importance of understanding like the racial disparity that we see within this space. And just quickly, next step. So I'm actually starting another study in August, looking at women as they're going through treatment to understand what's contributing to maybe like differences in blood pressure, because now we're seeing like variations in blood pressure and how that and their stress experiences, and distress may contribute to cardiovascular disease. So that is coming up next. I have my contact information here, and I'm sure Melissa and others will be free to share it, but please feel free to contact me should you have additional questions or want to talk more. Thank you very much.
Dr. Sutton, thank you so much. That information was amazing. And I just wanted as a reminder to everyone, you can, if you would like to post, if you're joining us with Facebook Live, you can feel free to post your questions in the comments. And then I also just wanted to let everyone know that, the information that we're talking about today is obviously fantastic information for education and information. Just make sure you also check with your physicians regarding all of the information that you're receiving today. And we are going to have time for questions and answers at the end of our presentation. All right, we are ready for our next fantastic presenter. Thank you again, Dr. Sutton.
Well, thanks, Arnethea. Can everyone see my screen?
Yes.
Yes, we can.
And can you just confirm for me that it's you can see the full presentation mode and not the slides with my notes?
You're still on your presenter view, Alex.
How's that?
Good.
Perfect.
Okay, well, great. Thanks, Arnethea, for the background. Just a little bit about myself, other than my intro. So Alex Lucas, I am a behavioral scientist. I work in both the Pauly Heart Center and the Department of Health, Behavior and Policy. Really, I've been focused on physical activity as a means of improving health and quality of life since I left my university at undergrad level. I originally am from Zimbabwe in Southern Africa, and I did my training in what is most similar to physical therapy in this country. So, once I came to the States and I'd started working actually in cardiovascular rehab, I found myself in a space where I realized that a lot of cancer patients, I was in a position to work during my training, that a lot of cancer patients also have need for interventions that are focused on physical activity. And so I just want to talk a little bit about the importance of physical activity for cancer survivors. And when I say cancer survivors, I typically am talking about anyone from the point of diagnosis onwards. And really, I'm going to try and give some strategies, a little bit of background, some of the details and the technical sort of research related stuff, but then some sort of practical approaches that you can use when thinking about how to incorporate physical activity into your lifestyle. So, just to start off, why is physical activity important for heart health amongst breast cancer survivors? Well, it's important for everybody, but it might be especially so for breast cancer survivors. And this is because as Arnethea presented, many of the risk factors for breast cancer are shared and cardiovascular disease are shared. So things like obesity, physical inactivity, hypertension, diabetes, smoking. And when we look at the incidence and mortality, so if we look at incidence, that's the green line, there's some good news here. So we're starting to see, since the decline in rates of smoking, things like declines in rates of smoking, we're actually seeing a slower or less numbers of people being diagnosed with cancer. We're also seeing mortality rates go down as our treatments become better. So what this means, though, is that there's a much larger number of people who are living a long time with cancer. And what that has led us to discover is that the majority of these cancer survivors are ultimately dying of cardiovascular disease. And that is especially the case with breast cancer survivors. Part of this is related to age. As I said, women are living longer post-diagnosis and treatment. So it's just natural that as we age, we are more at risk of cardiovascular disease as we put on weight, as we develop things like hypertension and diabetes. But some of the things that are important to think about are sort of limiting those risk factors once we have a diagnosis or once we know we're going to be going through treatment for breast cancer. So I think also really important to think about, well, that's all well and good, adding physical activity, but what are some of the challenges that we know are faced by women as they are dealing with the sort of situation where they've been diagnosed, going through treatment, getting back to normal life. We hear from a lot of women that fatigue is prevalent, and probably a lot of cancer survivors in general. If you mention cancer, people think fatigue, being tired. And as Arnethea, brought up that nice slide and showed a whole lot of these different symptoms that women talked about. The other thing, and a term that I'll use, is called exercise capacity. And this is somewhat linked to fatigue. And you remember the shortness of breath, the SOB. So this would be things like the ability to do work physically with your body. And that could be walking to the bus, that could be taking the stairs at work, that could be doing some gardening, that could be walking with a spouse or doing things with your kids. And so once we have some kind of cardiovascular impact, exercise capacity can diminish a lot. So there's a couple of different mechanisms for this, but which we can unpack a little bit. But this is really prevalent in patients who've been treated for breast cancer. And so those are some of the sort of direct impacts. But then there's a lot of other challenges that are faced by women if they're trying to start a lifestyle program or become more physically active, certainly post treatment. And those are things like, is it safe to exercise? Do I have the adequate knowledge to embark on an exercise program or a physical activity program while I'm undergoing treatment or whilst I'm recovering? Certainly you might have pre-existing risk factors that would make safety and knowledge about safety important. Do you have the support you need? Do you have access to things like facilities? Can you get transport to a location that is going to allow you to do the kinds of activity that we think is beneficial? And so because of these challenges, it's not surprising that data shows us that only about 50% of general cancer survivors are meeting physical activity guidelines. And when you add in things like nutrition and smoking, it's only about 5. So what this is showing us is that there's a lot of room for improvement. And certainly one way to start improving is just by making it more common knowledge that these are things that we can do, things that we have control over when we are going through diagnosis and treatment for cancer. We look at the physiological benefits. Obviously, today we're here talking about cardiovascular health. And so cardiovascular health, when we hear that term cardiovascular, oftentimes we think about the heart, and certainly that is the sort of central aspect of a cardiovascular system, a heart that as it beats distributing oxygen and nutrients around the body, but it's also the periphery, right? And so what we mean by that is it's also the way the tissues of the body, in particular the skeletal muscles, use oxygen and use nutrients to be able to do things like activity, whether that be walking or swimming or going upstairs. And so, chemotherapy, we think, can damage both of these components. It's not just the heart, it's the tissues that use the oxygen that the heart delivers. And in a similar fashion, the brain is another organ that also needs a healthy blood supply. So if we're talking about the periphery, we also know that maybe things are being affected in the brain as well. And so that's important because of cognition as well as mood, right? And then we know a little bit about metabolic health as well. So that's things like risk for diabetes, the way your body uses blood sugar when it's available to it. All of these factors together can lead to like what's called an inflammatory state in the body, which can also drive sort of secondary comorbidities. So they're going back to the situation described by Arnethea earlier, and that treatment for breast cancer might actually cause hypertension. And not to overlook things like stress management. Obviously, it's a very trying and challenging time psychologically being diagnosed and treated for cancer. And so, stress management is really important as well. We know stress management is closely linked to heart disease too. So some of the other benefits of physical activity, this is just a quote that I think really nicely encapsulates what we're talking about. Physical fitness achieved through regular exercise and or spontaneous physical activity, and actually that's the part that I'm going to emphasize most today, confers resilience by inducing positive psychological and physiological benefits, blunting stress reactivity, protecting against the adverse behavioral and metabolic consequences of stressful events, and preventing many chronic diseases. So I think that really captures all of these aspects. So it's not, one thing, it's the culmination of many things that we deal with in this situation that place us at risk. Also really important to think about quality of life. And another benefit of physical activity, it's not just about, losing weight or, because you're trying to do some event, or it's really about quality of life. And so, we think about this as being a number of components that are the foundation for quality of life when we talk about behaviors. So as I mentioned before, stress management, nutrition, as Samantha is going to talk about, and what I'm focusing on here, physical activity. And all of those, based probably on the foundation of sleep. And those of you who've been through treatment can probably recall changes in your body, maybe as hormones, fluctuated, stress of what was happening. Probably you had some sleep disruption. We know that things like sleep disruption then make it harder to feel like exercising or engaging in physical activity because we're tired, or we make poor food choices. But we think when we're taking care of these foundational behaviors, that then we can, impact a sort of more proximal, if you will, health-related quality of life domain, such as fatigue. So, as mentioned, doing these things might help us to feel less fatigued. Physical activity counterintuitively actually leads to reduced experience of fatigue. And that overall, when we're taking care of these domains, things like fatigue or pain or sleep disturbance, that really leads to a beneficial overall sense of well-being. So, hopefully I've established that, physical activity is important, but how much is required to derive benefit? And so, there's certain organizations that put out, very specific guidelines for Americans. And actually, one of the things that's really cool is that in recent times, we've discovered through research that, the recommendations for people who are going through treatment and survivors of cancer is not any different. For a long time, there was concerns about safety, but research has shown us that, you can safely engage in exercise. You just need to be a little bit more cognizant of a few things. So, we think about a physical activity continuum. And so here, what you have is on the left, the blue, we have sleep. So that's doing no physical activity. And on the far right, that would be running, or whatever you can imagine as being intense exercise. A lot of the guidelines focus on the right part of this continuum. And really what I'm here to tell you about today as well is that it's important to think about reducing the sedentary behavior. That is as beneficial, and certainly during treatment, as the more intense aspects of physical activity. So guidelines for women with breast cancer. So here's one example that would get you to the guidelines. You could do walking on a sort of level, brisk, a level surface, at a brisk pace. And this METS is just a measure of oxygen utilization. And if you did this for 30 minutes, you would need to do that about 4 times a week to get to the guidelines. So 4 times a week walking for 30 minutes at a relatively brisk pace is going to get you to the guidelines. You can also get there through doing things that are part of your activities of daily living, right? So, if you drive to work, you might park your car a little bit further away from your office. Or if you're going shopping to the grocery store, you might park your car at the back of the car park that gives you a little bit further of a walk in. Or if you work in a building that has multiple floors, you could take some stairs. So it's important to think that, think about the fact that you can get to these guidelines via different pathways. And really to just, emphasize this importance of sedentary behavior and reducing that, here's an example of somebody who's meeting the guidelines. And so that is the green bar to the left, where someone is doing that 30 minutes of walking, as I've previously shown, and that's going to get them to the physical activity guidelines. However, during the rest of the day, you could see there's plenty of opportunities to be doing absolutely nothing given the sedentary environments we now live in. Sitting down for food, working on a computer, sitting down for transport, watching TV, and so on. So, really importantly, you might not feel like you can exercise, but you could certainly break up some of this sitting time during the day, and that's going to lead to benefits in and of itself. So what are some of the practical approaches that you can take to adding more physical activity? during treatment. So as I mentioned, a lot of the early research was focused on survivors who are many years out from treatment because it was considered safe. We didn't have to worry about, are there things that would be harmful to a patient who's in the middle of treatment? We now know that we can start activity as soon as you begin treatment. And we've got a number of studies here at DCU that have been looking at this, both in breast cancer and lymphoma patients, two populations of cancer patients that receive similar types of therapies that are known to cause damage to the heart. And so things that are important are timing the amount of activity you can do based on when you receive treatment. So this is an example here where you might see, here this red flash is when you would receive treatment. And obviously at that time, those first few days after infusion, maybe a week, you're going to feel pretty low, probably not be able to do much. But as you recover from that treatment, you should feel or be able to do a little bit more. And then that's when you need to take the opportunity, say, add in a few minutes of walking more at that time. But being kind to yourself and also recognizing when you need to rest and when you need to up your game a little bit. What about after treatment? Well, there's a lot of tools available to us at the moment, things like wearables. So many of you might wear watches that count steps, can give you an idea of the amount of activity you're doing. That's really helpful for doing things like setting goals. So if you noticed I only took 2,000 steps yesterday, or maybe today I'm going to try and take 2,200. We say about a 10% increase per day or per week is a good target to have. And this is all what we call self-monitoring. By paying attention to what you're doing, you're learning about what your patterns are. You might learn that, I had a treatment or yesterday or last week, and so I'm not feeling great. I saw that I took way less steps. And so now you can then make adjustments based on what your patterns are, because it's individual for everybody. And really this process over time helps you identify barriers and other opportunities that you might have to engage in more activity. And then there's other things like, motivational tricks, we call them. You could be involved with a group, someone who's going to give you a little message here and then, said, hey, we didn't see you yesterday, or did you manage to do any walking? Something like that. Group support, social support, really important. For folks who feel like they are really busy, don't have time to get to a gym or a space or park, somewhere that it's safe for them to walk, there's lots of things that we can do at home. We can do things like standing up from sitting on a chair a number of times a day. Often we're sitting all day, so that we can, add extras of these. We can do things like balancing. If you've had chemotherapy, you might have experienced some peripheral neuropathy or tingling in some of your, fingers and toes. Balance is really good for that. And then just some general toe raises. This is doing a push-up type activity against a wall. So there's always things we can do, even if it seems like a really small amount, that are going to be beneficial to us. And the importance of this is that, every little bit that you do stops your decline over time. So that by the time, let's say you're in treatment, by the time you reach the other side of treatment, you now have less to make up than if you've been doing nothing, because you've been feeling terrible, of course. But just doing a little bit is going to help you maintain function over time. And I will leave my questions for the very end. Hopefully there's some things that sparked some ideas and will drive some questions towards the end of the session. Thank you.
Thank you so much, Dr. Lucas. That was just amazing information as well. So thank you to both Dr. Sutton and Dr. Lucas. And we also have Samantha Haswell with us here, who's a registered dietitian, and we're so excited to have you here. Thank you so much.
Thank you, Melissa. I appreciate it. Can everyone see my screen okay? Is it still full screen for you guys for the actual PowerPoint?
It is not right yet.
Perfect. Thank you.
There you go.
Okay. So I'm going to be talking a little bit about nutrition, cardiovascular disease, and nutrition and breast cancer as well. A lot of the recommendations kind of coincide with one another. I am the dietitian over at Massey Cancer Center at the Adult Outpatient Pavilion. And right now I'm working with all the different cancer teams, including the breast team. So that's something to keep in mind. If you do have your provider there, we do offer like one-on-one nutrition there and things like that. So just keep that in mind if you are a Massey patient. So to start with, Arnethea and Alex both talked about this a little bit, but when it comes to cardiovascular disease and breast cancer, there are very specific risk factors that kind of coincide for both. Things like age, diet, family history, your alcohol intake affects it, hormone replacement, overweight and obesity, the physical activity like Alex was saying, and tobacco use as well. When it comes to more specifics, when it comes to diet, cardiovascular risk is increased for those who eat diets high in processed meats and red meats, refined grains, which is things like white bread or pasta frequently without doing whole grains, and sweets. And there's about a 22% higher risk for those who are having a diet high in those foods. Meanwhile, those who are eating diets high in fruits and vegetables, fish, poultry, and whole grains can see about a 28% lower risk for mortality from cardiovascular disease. When it comes to breast cancer, the guidelines are very similar. They have an inverse association with those healthy foods like vegetables, fruits, fish, poultry, and whole grains, or they've seen no association in some studies. The inverse association means that the more people ate of those foods, the less we saw breast cancer in those studies. In particular, it was found that diets that are high in fruits and vegetables, plant protein and plant fats, which is things like canola oil and avocados, and have moderate carb content, had a lower risk of the estrogen receptor negative breast cancer in particular. Some dietary risk factors we have for both of these is high intake of energy-dense foods, fast food, and sugary drinks increases your risk of breast cancer. And then the general Western diet pattern increases your risk of breast cancer, especially in premenopausal women. So what is the Western diet pattern? So in the West, we tend to focus on protein, in particular red meat is a big part of the Western diet, fried foods, a lot of refined carbohydrates, and less of a focus on fruits and vegetables. So when we refer to Western diet, that's what we're speaking of. There are a lot of ways to reduce your risk for cardiovascular disease as well as for breast cancer. So some of the ways you can do that is by increasing your unsaturated fats, which are the polyunsaturated, monounsaturated fats. So that's going to be things like omega-3. And the way these are going to do that is it's going to lower your bad cholesterol, which is your low density lipoproteins, and raise your HDL, which is your high density lipoproteins. Usually foods that are going to be high in unsaturated fats are things like fish, in particular salmon and herring and trout tend to have a lot of omega-3s. Vegetable oils like canola oil, avocado oil, soybean oil, safflower oil, olive oil, and sunflower oil all have a lot of unsaturated fat. Nuts have a lot of unsaturated fat, particularly walnuts do. Flaxseed and flaxseed oils and olives and avocados are going to be a good source of these fats. You generally want to limit the saturated and trans fats. Saturated fats, generally from the AHA, which is the American Heart Association, is recommended to be limited to less than 7% of your calorie intake. Trans fats, which are things like hydrogenated oils, are recommended to be less than 1%. And then cholesterol is generally recommended to be less than 300 milligrams per day. Foods that might have a lot of saturated or hydrogenated oils are going to be things like butter tends to have a lot of saturated fat. Commercially fried or baked foods tend to have some trans fats, particularly kind of baked goods that are put in little packages tend to have trans fat in them. And obviously fried fast foods tend to have a lot of saturated fat as well. Another one that's probably going to break some hearts, because I'm sure everyone has heard the rule that, oh, you can have a glass of wine, it's good for your heart. While polyphenols, which are things like resveratrol in wine, are good for the heart because they do help with the lining of the blood lining, can increase your risk of cancer. So according to the American Institute of Cancer Research, it is recommended that you generally avoid alcohol use. The reason they tell you to avoid this is because alcohol use increases your risk of developing head and neck cancer, esophageal cancer, liver cancer, breast cancer, and colorectal cancer. According to the Nurses' Health Study, which came out of the UK, risk of breast cancer increased by 21% in adult binge drinkers compared to non-drinkers after they controlled for their alcoholic intake. The reason they think that alcohol may possibly contribute to cancer is because when alcohol has ethanol in it, and when ethanol is processed, it turns into acetaldehyde, which is something that is a known carcinogen. There's also some thought that the inflammation caused from drinking can increase your risk, and alcohol tends to also increase estrogen, which can affect how cells divide. Another way you can reduce your risk is by choosing which meats you're going to eat. So generally, processed meats are associated with higher likelihood of developing breast cancer, and they're known to have a lot of saturated fat, so they put you at risk for cardiovascular disease. Processed meats include things like ham and sausage, hot dogs. Basically anything you can think of that comes like in a little package is likely considered a processed meat. Commonly, I am asked if it matters if it's nitrate-free. It does not. It's still generally processed meats are at the risk, not just nitrate or nitrate-free risk. Red meat generally is associated with increased mortality in acute coronary events. And it's been shown that high consumption of red meats can increase your risk of developing colorectal cancer. Red meats are going to be things like beef, pork, lamb, and goat, and any derivative of those. And generally, red meat, according to the American Institute of Cancer Research, should be consumed in 18 ounces or less per week to reduce your risk of colorectal cancer. Another way you can reduce your risk of cardiovascular disease and of breast cancer is with soluble fiber in particular. So soluble fiber is going to be found in a lot of your fruits and vegetables. In particular, things like apples and oats and berries can have a lot of soluble fiber. Some patients even take things like psyllium powders or fibers themselves to try and lower their cholesterol. The way that soluble fiber works is that it binds to cholesterol in your intestines, and then it's excreted in your waste. High fiber diets also help reduce your caloric intake, so they may help you maintain a healthy weight, which can reduce your risk of breast cancer. And high fiber foods tend to be high in phytochemicals. Fruits and vegetables are full of phytochemicals or antioxidants, which help fight cancer in general. I know Alex talked a lot about physical activity, so I won't go into physical activity too much. But generally, the reason that your doctor may pursue you achieving a healthy weight is because carrying excess body fat can increase your risk of postmenopausal breast cancer and your risk of cardiovascular disease. That being said, not every person who has an overweight BMI is necessarily at risk. Generally, when we're looking at those, it's a very generalized study. If you're someone who is maybe working out very, very frequently and has a known very low body fat percentage, you'll have to work with your doctor to really discover what your risk is in that regard. In general, physical activity is shown to reduce breast cancer risk and cardiovascular disease risk. So here's kind of like a summary, kind of nitty gritty of what the recommendations for your diet should look like. So this is the New American Plate. This was created by the American Institute of Cancer Research. Generally, they recommend that 2/3 or more of your plate is plant-based. So that means things like fruits, vegetables, whole grains, and beans. And then 1/3 or less should be based on animal protein. Or if you're vegan or vegetarian, it doesn't need to be. Another model I also really like to use in my patients, because I think it gives a really good summary of how you should eat for all chronic diseases, is the healthy eating plate. This was developed by Harvard. It's kind of a more laid out format of the New American Plate to give you an idea of what a healthy diet looks like. So things like limiting sugary drinks, drinking water and tea or coffee instead of those drinks, choosing whole grains as often as you can rather than refined grains. Those whole grains are going to be high in unsoluble and soluble fiber. The unsoluble fiber is going to be really great for keeping your gut healthy and preventing colorectal cancer risk. And then the soluble fiber is going to be great for keeping your cholesterol low and helping your just general body move. Both those fibers can help produce bowel movements and keep your gut healthy. Healthy proteins are going to be things like fish, poultry, beans, and nuts. And just like you do for cancer, you want to limit red meat and things like processed meats. Healthy oils, like we talked about before, are going to be things like olive oil, canola oil. You're going to want to limit butter or things that are high in saturated fat, and generally try to avoid those trans fat foods, which is things like shortening or lard. More veggies is always going to be better. In the US, we have a tendency to focus more on our meat when we create a plate rather than our vegetables. One of the main recommendations I give to my patients is instead of choosing your meat at dinner or at lunch, figure out what vegetable or what fruit you want on your plate first, and then figure out what you want to pair with it. Ideally, you want that vegetable to take over about half your plate so that you can make sure that you're getting enough of those phytochemicals and that fiber and all those healthy things that you need for a healthy body. And these are some graphics that kind of go over things a little more Specifically for you guys, just to give you an idea of those recommendations. So generally increasing your fruits and vegetables, increasing your whole grains, trying to get some plant proteins if that's indicated for you can be helpful. Something to keep in mind is that if you do have diabetes, plant proteins are very healthy, but you'll want to be careful about your carbohydrate load if you are including them in your diet. Generally, ways you can eat more plant foods is buying things like canned beans, keeping whole grains on hand rather than refined grains. So keeping some whole wheat bread in your kitchen rather than keeping white bread, having oatmeal available in the morning for you to have for breakfast, things like that. Trying to keep fruits and vegetables in your meals, and in particular, you can even throw veggies in your smoothies. Generally, if you create a smoothie, if you add spinach in there and then put a peeled green apple, usually you can't taste it. And then keeping some frozen veggies on hand to keep it easy, especially when you're having a tough day at work or you just don't really feel like cooking when you get home. There is no nutritional difference that is really significant between frozen veggies and fresh. And in some ways, things like broccoli, which can be steamed fresh or frozen, are more healthy when they're steamed or have more vitamin K. Generally, switching off those red and processed meats, like we said before, is important. This just gives you guys some tips on how to do that if you're going to do a plant-based diet. This is just giving you some tips on what those whole grains look like. So whole grains can be 1 slice of whole grain bread, half a cup of brown rice on your plate. Corn tortillas are considered a whole grain, or corn itself. And popcorn can be a really good fibery whole grain snack. And this just kind of goes over all those recommendations all put together. This might be kind of hard to see on your screen, but I would be happy to share this with you guys if you'd like it. This goes over all of the ASCR recommendations for cancer survivorship. And honestly, all the recommendations that are put out by the American Institute of Cancer Research are great for diabetes prevention and cardiovascular disease prevention. So it's something to keep in mind. The only thing I did not include on here is I did talk about salt. But when it comes to hypertension, something to keep in mind is trying to avoid using salt-containing seasonings as much as you can, especially when you're cooking at home. Be mindful that restaurants are going to use more salt than you think, and if you can't taste it that much. And then if you are using canned vegetables or canned beans, a great way you can get some of that salt off is by pouring those canned vegetables or beans into a colander and rinsing them with some cold water, especially since I know for a lot of people, those can be a really cost-effective choice. And then this is just a list of references here, and the ones in the bottom are ones that patients or people here might find kind of useful.
Samantha, thank you so much. And thank you to all of you. We're gonna, if you have a few more minutes, we're gonna move on to our question and answer period. We have a couple of questions that have come up. So now is the time. If you guys would like to post questions into the chat, now is a great time to go ahead and do that if you have not already done so. So we're going to move in. We've got some more questions coming in, so I'm gonna try to keep up with all of them as we move through. Someone keep time for us because I tend to lose track of time. So the first question is, I would like to know the effects of being a young woman who has gone through rigorous chemo, is on an aromatase inhibitor, and has had a hysterectomy, oophorectomy. So I think what they're asking, and please let me know if this is not correct, is what would the effects be as it relates to cardiovascular health or maybe health in general, if you can speak to that with all of those different pieces.
Okay, I guess I will start. So I think with being a younger woman, we typically think of that as having a decreased risk. But, you know, so recently I am doing an analysis of data here at our hospital. And what I've actually found is, and this is specifically for Black women, but actually younger Black women were more at risk of having arrhythmias than older Black women. But it was still, older age was still the risk factor for white women. And so I think, you know, we're starting to see some differences with regard to age and I think different races. With the type of chemotherapy, you know, like we all discussed, generally you see with the anthracycline-based chemotherapies more of a higher risk. And then I think, what was the other thing she mentioned? She said she had
They're on an aromatase inhibitor
Right.
right now, and then a hysterectomy and oophorectomy.
Right. So as far as the aromatase inhibitors, it's like I talked about earlier, the findings unfortunately are still so mixed with that. I will say there are studies out there that tend to lean toward the side that they may have some type of implications for our heart disease, but then there are others that say that's not the case. And so, my thing for individuals is any individual that's gone through treatment, ask the questions like as you're going through your survivorship journey to your providers. I provided that slide of like the symptoms that we typically see with heart disease or heart failure. So be aware of those. Don't think anything is too small. If you wake up one day and you feel way more tired than you generally do, then that's enough to talk to someone about.
Perfect. Thank you so much. Does anyone else want to chime in on that question?
No, I mean, I would just emphasize what Arnethea finished up with there is feel empowered right from the beginning, be willing to, keep track of things. So ask providers what they think. Do you need, imaging or some kind of follow-up to look more specifically at risk factors related to heart disease? Maybe if you have family history, not specific to cancer, but to heart disease, be empowered to take control and to seek that information from your providers.
Okay, thank you so much. Perfect. Thank you very much. So the next two questions kind of move into the food aspect. And then I have a couple of others, and then we're going to wrap up with a general question for all of you. And that is, one of them is, where does caffeine fall into drinks? And Samantha, that might be a good one for you to start us off with.
So in regards to this, it's going to depend on your physician as well. So you will want to talk to your oncologist before you start drinking a lot of coffee if you're like a very heavy coffee tea drinker. But generally for most people, 400 milligrams of caffeine, which is about a single cup of coffee, is generally considered safe, as long as you don't have other risk factors that increase your risk of having that high caffeine content. So I don't know if Alex might be able to speak to this more, but people who have like very high heart rates or things like that, they may not be someone who should be drinking caffeine. But if your doctor does not think that caffeine in general is a risk factor for you, there have been some studies that have shown there are antioxidants themselves in tea and in coffee that are protective against cancer. So if you're someone who really loves those items and wants, a cup or two in the morning or throughout the day, that's okay.
So interestingly, research with caffeine shows that people tend to either be a responder or non-responder to caffeine. So some people, two people can drink the same cup of coffee and have very different responses to that. So if you feel like you are a responder, like caffeine really does make your heart race a little bit or something like that, you might just be aware of that. If you are post treatment or going through treatment, maybe you want to limit the caffeine. But nothing too much more than that, I would say.
No, that's wonderful. Thank you both. And I never even thought of that some people are responders and some people are not. So thank you so much for that information. Okay, our next question is, are there any benefits or risk from other diets such as the keto diet following cancer treatment? Any thoughts on that, guys?
Yes, so generally, something I always want my patients to keep in mind, that any diet that tells you need to restrict an entire food item, it's not a sustainable diet. So that's one big thing to keep in mind. And it's not necessarily safe long-term. A lot of people will use keto diets because they are known for very fast weight loss. Going to break some hearts here, but initially when you start the keto diet, a lot of your weight loss is from water weight that you lose from not having carbohydrates. It's not necessarily true fat loss. Also keeping in mind that the keto diet promotes a lot of things that is very negative for cardiovascular health. So keto diet tends to promote having a lot of butter, having bacon in the morning frequently, eating red meat all day long. And while studies I think are just starting to come out that are showing that risk, because generally cardiovascular disease builds over time and keto goes in and out of being popular every 10 or so years. They just call it different things. Before it was Atkins, now it's keto again. Generally, you don't want to do a super restrictive diet. So a lot of the side effects of keto tend to be like things like constipation. Nausea tends to be a side effect because it is a very high fat diet. And you may not get enough carbohydrates from the really healthy foods. So things like whole grains tend to be omitted out of keto diets to keep the carbohydrates very low. And when you're doing that, you're not getting the soluble fiber from things like oats and whole grains. You're missing out on that benefit.
Absolutely. Would anyone else like to add anything to that question? All right, thank you so much. So just a couple of other questions if you guys have another minute or so. I know we're getting close to the end of our hour. The first question is, can you speak to the impacts of sugar? I know there's a lot of information about there, and those of us that have spoken to oncologists, you know, there's some mixed information about sugar. Can you speak to that in two ways: A, cardiovascular health, and B, cancer reoccurrence, if you are able to speak to that?
From a cancer and cancer reoccurrence side of things, there is a misinterpretation that cancer feeds on sugar directly, but it is a really more so indirect relationship. So sugar itself is not going to necessarily feed your cancer or make it grow faster, but an unhealthy diet and obesity and high body fat percentage can increase your risk of developing cancer. So it's not that having a piece of cake is going to make your cancer grow, but it's the overall diet as a whole. So if you are someone who eats a diet that's very, very high in refined grains and donuts and baked goods and sugary drinks, you may have more adiposity than someone else. You may have higher insulin levels, which can increase your risk of developing cancer. And if that's the case, that may lead to you developing cancer. But once you have cancer, people think that, oh, if I have something sweet, it's going to make my cancer grow. Doesn't quite work that way. I think some of that comes from when you get PET scans and you have the sugary drinks, then you're kind of like cancer lights up in the PET scan and people think, oh, that means sugar's feeding my cancer. It's not. Your cancers, unfortunately, are usually what we call hypermetabolic, which means that they love to steal whatever nutrients they can get more than your healthy cells. They use more energy, and that is why it lights up. So big thing is, should you eat a bunch of added sugar? No, like you shouldn't necessarily have, a donut and a piece of cake every single day. But if you are going out for your friend's birthday, or if you've been wanting a cookie, eating a single cookie or a slice of cake is definitely not going to make or break your cancer risk. From a cardiovascular standpoint, it shouldn't either. The risk with sugar and cardiovascular disease is also more so related to your risk of developing diabetes with a diet that's very high in sugar and refined grains, and then your risk of obesity or high levels of body fat with eating a lot of those foods. And if Alex and Arnethea have anything else to add, please go ahead.
All right. Well, thank you so much. So before I wrap, kind of bring us to a close for this evening, we had someone ask if you are able to share your presentations. If you are, if you could just let us know it here for the girls. You don't have to answer that right now. So you can think on that piece. And then also, I just wanted to spend the last minute, if each one of you could maybe, if you feel comfortable, give us, whatever your takeaway message is from our panel discussion this evening. And then I'll bring us to a close.
Okay, I guess I'll start. I think my takeaway message is that, and Alex alluded to this already, and you should feel empowered now that you have this knowledge to, one, share it, but also use this when you're talking to your providers. Bring this up, bring what you learned up, find out if you're at risk, find out if there are assessments that can be done given the type of treatment, and don't let up about it. You know this now, you know that cardiovascular disease in women overall is an issue, and particularly for women of breast cancer. So, communicate and speak your mind and advocate for yourself.
That's great. As a wrap up, I'll just say, obviously you talked a little bit about exercise and physical activity. There's these guidelines, which are, might seem like they're out of reach for people. I would say just doing something is the most important thing. It can be a 5-minute walk. One of the things from a psychological perspective that we found to be really important for a lot of survivors in the middle of treatment is that the cancer experience takes control out of your hands. There's not a lot that we can do. We've got to listen to other folks who are going to tell us what treatment to take, what decisions to make. Doing something like a short walk during the day or some activity, that gives you a sense of control. And that's really comforting to a lot of folks. So, maybe you can link up with a friend or a partner or another survivor and do this together. As I said, just any little bit is beneficial.
I think my big takeaway is I threw a lot of nutrition information at you. Don't try to do everything at once. If you feel like you are following a Western diet, do not do the all or nothing principle. Start small. Maybe your first thing will be like at dinner, I'm going to make sure that one meal has half a plate of vegetables, and then my other meals I'll work on later. Make small changes first. Eventually, people tend to see, even just with that one small change, they might see some difference, and that might push you to do more small changes. And keep in mind that it's not all or nothing. If you want to go out with friends and you are dying for a burger and some fries, you don't have to be 100% on it all the time. I'm sure Alex and Arnethea can say the same thing. We know this information, but we still eat what people would call unhealthy foods occasionally. Your body is very adaptive. It is not all or nothing. A lot of people used to say that 80-20 rule. It's about right. You can occasionally go out and have something that you may not deem healthy, and that's okay. It's about starting to make the small changes, and then over time, working time towards that more plant-based healthy diet.
Thank you all. Thank you to Arnethea, Alex, and Samantha for leading us in this informative and really enlightening discussion. If you are interested in learning more about your heart health or getting started with Here for the Girls support, please complete the brief survey, which has been posted to the chat along with Facebook. You can also visit us at hereforthegirls.org to learn more. And be sure to check out our calendar for upcoming events, including more ways to join virtually. And I just wanted to say thank you again. And we hope that everyone stays safe and well and take care. Thank you again, everyone.